The motivation behind the study comparing risedronate with denosumab in patients on glucocorticoids was to understand whether this medication, denosumab, which has been used and continues to be used in postmenopausal women and men with osteoporosis, had efficacy and safety in this population of patients. And we're interested in it in part because we understand that when patients take glucocorticoids, one of the problems is a reduction in rank ligand and an increase in osteoprotegrin. And denosumab makes biologic sense in that setting as a way to counteract that phenomenon that occurs biologically. The 12-month study published in Lancet Diabetes Endocrinology showed that not only was denosumab non-inferior to risedronate in increasing bone density at the spine and at the hip, but it was actually superior. And it was generally well tolerated. There weren't any untoward safety events per se, and the fractures looked similar between the two groups. And also, another important finding was there didn't appear to be any increase in infections, and that's one of the questions that we have as rheumatologists when we're using glucocorticoids. The 24-month results extend the original findings and show that it continues to look better. Denosumab continues to look better than risedronate, and the bone density changes appear to continue to increase. So very similar to what we've seen using denosumab in older women, there doesn't seem to be the same level of plateauing of bone mineral density changes that we see with bisphosphonates, but there's more of an upslope in the effects on bone density at the spine and at the hip. The most important thing for rheumatologists is that this is a condition, the use of steroids and the effects on bone, that has been under-identified and under-treated in the general population. Now, many rheumatologists are very attentive to the problem, but we need to work with our colleagues in general practice and primary care to help them understand the magnitude of this problem. And now it looks like we have another very viable treatment option that we can consider in a circumstance where people are underdiagnosed and undertreated. Yeah, there wasn't any. We looked at a number of subgroups, and those results were presented here at this meeting as a poster, but we weren't seeing effects where one drug looked better or worse than the other in a specific subgroup. That said, there are certain patients in whom many of the treatments that we have currently available in this setting would not be optimal, and that might include younger women with pregnancy in mind, where we're not terribly excited about the use of medicines like bisphosphonates. Denosumab might have a selective benefit there. We also believe that this problem of an increase in rank ligand and a decrease in osteoprotegrin may be particularly relevant early in the course of steroid-induced osteoporosis. So it may make particular sense to think about denosumab as an earlier therapy in people that are at high risk for fractures. Regrettably, the clinical trials done of patients on glucocorticoids are never large or long enough to really answer this question in a definitive way. And there's only been one study, the teriparatide compared with the lundronate study, that was very enriched for older people who had a very high fracture risk, that actually demonstrated a small but significant reduction in vertebral fractures. All of the other studies that have been done to date in the primary analyses have not been able to show in the initial phase that there was fracture risk reduction. That said, when you combine some of the bisphosphonate studies, when you do a meta-analysis, it appears that the fracture risk reduction is very similar to what we see in other disease states, and we have no reason to think that the denosumab data wouldn't play out in a similar fashion. But it would be helpful to have longer-term follow-up, perhaps from observational studies, to address this question further.